device management of hypertension beyond renal denervation. Mel, it's a great pleasure to invite you to start our sessions off.
Thank you, President. Thank you, ladies and gentlemen. It's an interesting title to be given. If you think about 5 years ago, it would have been inconceivable to get a request for a talk like this, and probably a lot of you in this audience believe it should remain inconceivable even at this present time. The reason I've left the declarations of interest on there is so that you can see that we are involved in BARTS in a number of trials of device-based therapies of hypertension, and it's my belief that we should be looking at studies and trials and perhaps not offering these as a standard of service. You may be asking the question, do we need more devices for hypertension? We've got good drug therapies, but you are aware that resistant hypertension is a major issue, and I'm sure that all of you in your clinics have some patients who don't seem to come under control, even with the most attentive approaches. In the European Society of Cardiology and Joint ESH guidance, they have now given, an indication for the use of renal denervation and baroreflex activation therapies. Not all patients, however, are anatomically suitable for renal denervation, which requires a landing zone for a ablation catheter, and therefore there are anatomic constraints, plus as well patients should not have denervation therapy if they have in situ renal stents or renovascular disorder. And some patients actually don't even want to have an irreversible renal sympathectomy. And furthermore, in our hands, we have seen that renal denervation isn't always successful. We presented this data at the European Society of Hypertension recently. What looks like an interesting initial promising blood pressure response is marred by the fact that at 6 months we see average blood pressure lowering that's much smaller than reported in the Simplicity HTN2 cohort, plus very striking heterogeneity of blood pressure responses. And as our patients complete their 2 years, some of them are actually asking for other device-based therapies of hypertension because they simply have not achieved what they want. So what's out there for them? Well, there's quite a lot of choice now compared to before, and most of this is investigational, so you're going to be hearing about treatments for which there are very little randomized control data apart from baroreflex activation therapy. But I think you should know about iliac arteriovenous anastomosis because of interest, and hopefully there'll be some interesting trial results next year. And in the short time I have, I'll mention deep brain stimulation and carotid body ablation, but I won't be talking about CPAP therapy and certainly not about device-guided breathing. And in this audience, there'll be a number of you who are very familiar with the Baroreflex, a mechanosensor situated in the carotid bulb, which senses stretch and transmits to the brainstem responses indicative of distension that allows downregulation of sympathetic outflow, upregulation of parasympathetic outflow, and therefore a potential target for intervention in neurally mediated hypertension. And there's quite a lot of data to support the use of baroreflex activation. And in fact, the first devices for this were available in the late 1950s and early 1960s, but you can imagine at the time that technology wasn't really fit for purpose. There were issues around electrode tissue interfaces, problems with batteries, problems with programmability of the devices. And so baroreflex activation therapy, like a lot of other surgical approaches, came and disappeared. Now we have a new platform, which is this NEO actually refers to the second generation iteration of a first generation device, Barostim or baroreflex activation therapy. And the idea here is electronic stimulation of the baroreceptors to downregulate sympathetic tone and improve blood pressure control. So it's almost like a pacemaker system that requires an implantable generator, which obviously has a battery life. The battery life is about 3 years at present, and it's on continuous stimulation. There's no loop feedback to give you systemic blood pressure control feeding back into the device, so it's on all the time. When it's on, it has a lead from the generator implanted in the neck onto the carotid sinus. It's sutured there, so it does require the skills of a vascular surgeon or a neurosurgeon. This is one that the cardiologists will not be interested in. And then the programmer system is now relatively straightforward. A laptop and wireless RF activated programmable control, which allows now reasonable regulation of the blood pressure parameters. And it's become a lot more simple to do, unilateral incision as opposed to bilateral in the first inception, wireless as I mentioned. And so what data is there out there? Well, there is a lot of trial data in respect to this particular technology. I'll just explain a little bit about it. You seem to have a nice dose response curve here when you implant the device. And so there is a thinking that actually at the time of patient selection, you have them on the table, you're about to implant the device, you can look and see if you can achieve a dose response curve. And if you can't, then you might think twice about putting in a 20,000 euro device, which I think is reasonable. So as you up the voltage, the heart rate decreases, so increasing parasympathetic tone and quite profound reductions in blood pressure. And this has been tied into now brainstem activation shown on PET-CT scanning. So that's as the device is switched on. In this study here, which I think is a form of systematic torture, the patient's implanted device was turned on and then turned on and then turned off with a very substantial swing in systolic and diastolic blood pressures and a reduction in whole body sympathetic activity as measured by MSNA, which we accept is a crude measure of sympathetic activity, but it's one that is available. So quite striking differences in this very hypertensive patient. Blood pressures up to 250, systolic coming down to 120 or so. And in the very first proof of concept study, the reason this slide is interesting is because we now have some 4-year data, albeit in very small numbers of patients, only 18 patients in total. But what there seems to be is durable, possibly increasing blood pressure response with time, such that the final blood pressure reduction is very substantial indeed compared to other devices that we are aware of. And although we never make much of medicine's reduction, it's not the main aim of our therapies, that is something that patients do like quite a little bit. And that was the very first proof of concept study. It led on to a randomized control study, which actually ended up failing on its primary short-term efficacy and safety time points. And I'm not going to run you through the data of that study, but just to say that in this study here, there were the ABPM on this is 24-hour mean. Again, first year and second year, very substantial reductions in 24-hour daytime systolic and diastolic blood pressure and heart rate as well. So quite encouraging early responses. And perhaps not surprisingly, if you improve blood pressure to that degree, you will see regression of left ventricular hypertrophy. And we're used to seeing that in the patients with resistant hypertension that we treat in the hypertension clinic with drugs. And there's been emerging data for this in device-based therapies. Here's some early data in small numbers of patients. And this is what the original device looked like. So there's a bilateral implantation of these rather unwieldy-looking electrodes with a rather large generator as well. And that's been simplified following on from the results of the initial pivotal study, the randomized control study, to a single-side implantation, which seems to be as effective in blood pressure lowering, a much smaller generator. And now the mean implantation time has been reduced from 200 minutes to about 100 minutes, and patients stay in hospital for a much shorter period of time. And therefore, this is much more appealing for both patients and for operators. And in the study that's been done to date, it looks like there's much less in the way of short-term safety issues with the patients. Things like wound infection, pain at the site, etc., are all reduced. They claim some longer battery life and lower cost, but still it's quite an expensive treatment for purchasers or commissioners to countenance at this stage with the data sets that are currently available. And just provocatively, in the Barostim Neo trial, which is the new generation technology, they have looked at the effects of Barostim in patients with prior renal denervation, at least 6 months after renal denervation with radiofrequency ablation. They've seen the effects of Barostim, Baroreflex activation on top of renal denervation, and there does seem to be quite a lot of blood pressure reduction. And this possibly points towards lack of importance of renal sympathetic signaling for Barostim to work, and certainly there are canine experiments where denervated dogs have undergone, renally denervated dogs have undergone Barostim. They've still had substantial reduction in blood pressure as well. So this is about perhaps a whole body sympathetic downregulation, improvement in vascular tone without necessarily involving the kidney, although there are some effects on natriuresis seen. And here is here's the data on the patients treated with renal denervation. I just mentioned that. So quite substantial reduction in blood pressures there. So Barostim seems to have some promise, and at the moment they're considering trials in chronic kidney disease, and a more detailed randomized control study is being configured in the USA with the new generation device. Now I'll move on to the iliac arteriovenous anastomosis, because this was something when I first heard about it, I thought it was rather bizarre. Because fistulas, by and large, in medicine, we try and either close off or avoid the development thereof. This was discovered as an incidental finding by physicians trying to alleviate breathlessness in the COPD population. They devised a peripheral arterial iliac arteriovenous fistula with relatively low flow in order to improve mixed venous oxygenation and reduce breathlessness in the COPD population. And they found the blood pressure signal in a small subset of patients that allowed them to then go on and undertake a small pilot study. When I say small, I'm talking about 8 patients. And that showed some positive data. Nonetheless, they've gone on to now put together a randomized control study with 100 patients, and we're involved in that in BARTS. For those of you who are interventionists, this is what it takes: a delivery device, a crossing needle. This is a nitinol stent. So nitinol is a nickel titanium memory wire, which is very short in length, only 4 millimeters in diameter. So it creates a low flow fistula between the iliac artery and vein just above the level of the femoral head. So it's a femoral approach into the femoral artery and vein. And this can be done relatively easily by an interventional cardiologist or radiologist in the cath lab, and clearly seems to result in blood pressure reduction almost immediately on the table, as well as sustained blood pressure reduction thereafter. And perhaps an appeal of this particular technology, if it proves to work in the long term, is that it's fully reversible, because if your patients don't like it, you can put in a covered stent and the fistula will be closed off. And I guess everyone's keen to know how's the mechanism of action, and I have to say that right now the manufacturers don't really understand exactly how it works, and we're trying to put together studies to interrogate this further. But clearly you're going to increase your cardiac output by an amount that is equivalent to flow across the fistula. You'll improve renal perfusion with this, and you will also reduce total peripheral resistance. And there are some blood pressure reductions. So this is within the COPD studies. This was the signal that they saw that made them take the investigation a bit further. Some blood pressure lowering at 12 months in these patients who had no adjustment of antihypertensive medication. And there's the blood pressure lowering in the different stages of hypertension in these groups of patients. So remember, this wasn't a hypertension study, but they just happened to have, obviously, hypertensive patients in a COPD population being treated actually primarily for the breathlessness. And so all of the different groups of patients evidenced blood pressure lowering, so even at lower levels of hypertension or even pre-hypertension. And this is just a post hoc analysis, so obviously we're not getting too excited about that. There are some predictable effects on cardiac physiology with reduction in mean arterial pressure and some slight increases in cardiac indices, so right atrial pressure has gone up. The cardiac output's gone up by a little bit more than the flow, which I'm not sure is clearly explained. This SVR has come down, and pulmonary arterial pressure goes up, so you can't put this into patients who have pre-existing pulmonary arterial hypertension. That would be risky. We've improved venous oxygen saturation there as well. So there's some interesting effects on physiology. What does it do to 24-hour blood pressure monitoring? Well, again, it's a very small number of patients in this particular study, but there are some effects on 24-hour monitoring, which again, I guess, are just pointing us towards the need to do further investigation. And so what's the downside of this treatment? Well, the downside is you may develop venous stenosis, and this is a particular problem in patients in whom you put fistulas, but you've got to bear in mind as well the comorbidities may dictate to some extent the rates at which venous stenosis develop. And in the sickest populations, those with very advanced CKD who have fistulas for dialysis purposes, or patients with very advanced COPD who have minimal exercise tolerance, then venous stenosis rates have been a little bit higher, but they are reduced in patients with less severe disease, and the prediction is that in the hypertensive cohorts we'll see less in the way of venous stenosis, and the patients are mandated to wear stockings for at least a couple of months after the procedure is done, and to report any leg swelling that occurs as it is relatively easy to deal with the venous stenosis. And once again, I guess patients do like this idea that you have a reversible therapy for blood pressure. And for those of you who say, well, you know, we don't see blood pressure lowering in the renal clinics in hemodialysis patients, I think that's very acceptable. When you put in AV fistulas, there hasn't been a lot of reported curing of hypertension, and hypertension control rates in renal clinics are actually exceedingly poor. Probably around 10 to 15% of patients are at target in this high-risk group who would benefit most from blood pressure control. The KDOQI statement is that AVF, arteriovenous fistula, is a vascular access of choice in hemodialysis patients, but actually there is nothing more than a few case reports in the literature to indicate the effect on cardiovascular hemodynamics. And so there are some anecdotal reports of increased cardiac output states and heart failure, and quite a lot of reports of sepsis and fistula-related complications locally. But just this one nice study, effect of fistula formation, where they undertook a lot of proper cardiovascular measurement using pulse wave velocity, applanation, tonometry, proper blood pressure monitoring, and total body water measurement. And they showed that in a group of 43 patients, they had 30 that had successful peripheral AV fistula formation, end-to-side anastomoses, and that they had changes maintained at 3 months in terms of reduction in blood pressure, both peripherally and centrally, improved reduction in pulse wave velocity, and improved cardiac indices, so ejection fraction, and this was without changing total body water. So I think there's a lack of data out there about the effects of dialysis fistulas, and there's almost no published data on the effects of a ROX arteriovenous fistula, so it remains to be proven. And just in the dying minutes, I'll just tell you one or two other new things on the horizon. The days of deep brain stimulation have moved on from this to this, a pacemaker-like device implanted in the subclavicular region with a lead that's tunneled up towards here, and thereafter electrodes that are placed under surgery and proper neurosurgical conditions into the periaqueductal grey. This is actually obviously a very time-consuming procedure, and one that very few patients would countenance for treatment of their hypertension. And there's been just one or two case reports that this is a successful means of lowering blood pressure through probably, again, down-regulation of whole-body sympathetic nervous system activity. The indications in the case reports to put in deep brain stimulation were not for hypertension. It was done for pain syndromes in both the reported cases. And in both of those cases, even if the pain returned, the blood pressure remained under control. And in one of the cases, the patient's antihypertensive medication had to be reduced and stopped. So I think this is something that's currently under investigation by colleagues in Bristol. I think it is of interest. It's impossible for me to recruit patients into the study. Nobody wants to have a deep brain stimulator for their hypertension. They would rather have the stroke. And then the final thing is carotid body ablation is a novel treatment being pioneered by colleagues again in Bristol and Poland, looking at this effect of ablation of this peripheral chemosensor, the carotid body, which is the most highly perfused organ in the body per gram tissue weight, and is important in the regulation of blood pressure through sensing carbon dioxide, oxygen, and pH. And there are some proof of concept studies going on at the moment which are recruiting and hopefully will report in the new year. And so I'll end there with just this conclusion that I think we're very early days in the device field, but I've got a lot of patients who are struggling for blood pressure control. Some of them actually can't take antihypertensive medications, so they don't fulfill a definition of resistant hypertension. That's why I use the term uncontrolled. And I think clearly we don't have a lot of randomized controlled data. We're very early in the curve, and the therapies are expensive, so we need to be a little bit cautious about where we're going. As I say, we're not offering these as a point of service in any of our clinic. And in fact, I'm device agnostic. So if someone comes to me and I can't get their blood pressure under control, I can offer the patient a series of trials, and it doesn't matter to me what the patient chooses. They'll generally choose reversible. They'll generally choose done swiftly. They don't want their kidneys messed around with. They don't want their brain messed around with. They don't want anything going on in their neck. So the patients choose to have a peripheral iliac fistula. And actually in that study so far, I can tell you off record that we're seeing substantial blood pressure reduction. We hope to report on the trial early in 2014. Thank you very much.
Well done, Mel. Well done. Right, we have time for some questions. Wayne, just if you hang on, they'll bring a microphone to you.
Hi. Why don't centrally acting drugs work then?
They do work, but patients don't like taking them. I mean, I use moxonidine up to 800 micrograms BD in the patients who can tolerate it. It's a brilliant blood pressure lowering drug. I use clonidine patches, but patients generally don't tolerate the centrally acting drugs at the dose. They're not acting just on blood pressure control, are they? They're affecting a number of other things. The dry mouth puts them off, the sedation puts them off, the pill taking puts them off. So they do work. All the drugs work. No one's saying drugs don't work.
Well, in my hands they don't work, but I admit that by the time I get to them, I'm on fifth line and I begin to wonder if patients really taking stuff.
Well, you know, we take our patients to the lab and we do a days of observed tablet taking. We do a 24-hour monitor afterwards. Yeah. A few of them will drop their blood pressure quite strikingly. Some of them will crash. Yeah. Some of them need to be hospitalized overnight. But by and large, the majority of them don't. If you're 45 years old, you've had a stroke. If you're 27 years old, you've had a coronary. Generally speaking, they take their medicines. And when we bring them in, they don't have a blood pressure response.
Adrian?
Adrian Brady, Glasgow. Mel, thank you for a great talk. And like you, I do love interventional things for all sorts of stuff. But the thing about it, I mean, you must have, like me, referred patients for fistula closure because of angina or worsening heart failure. I've certainly closed fistulas because of problems. Now, these new techniques, if this was a drug, you'd have to show 5-year outcomes with mortality benefit. Of course, this is not a drug, and it has a morbidity of insertion, but the sort of science of just shoving them in, whereas if it was a medicine, you'd have to evaluate it very carefully. I wonder what you want to comment about that.
Well, I mean, I think we're just evaluating them in trials, and there's no service here. I mean, they've got CE mark, so whoever gives CE mark is perhaps responsible for thinking about, adoption and uptake. In the UK, we won't be taking up any of these things without, I mean, even renal denervation is taking a long time to come, and I'm not in any rush. I'm quite happy to only do this in the confines of clinical trials.
Okay, Matt, we've got a question here from Peter Sever, so yes.
So I'm very curious as to why the fistula procedure works to increase renal flow, because when people drill holes in water pipes on the way to your house, this doesn't improve the water pressure in your house, it doesn't improve the flow.
True.
So
I don't know if they've measured flow specifically, Darryl. I mean, it increases cardiac output, and so cardiac output goes
so we
up.
don't know about the kidneys?
Well, I think they're assuming that with kidney cardiac output increasing, renal flows increasing, but they've not done catheter studies to look at flow in the renal arteries as a result of.
I think that's a very bad assumption, because the reason cardiac output goes up is there's a fistula, and we should assume that all the other flows go down rather than up, unless there's an inotropic response, which we as cardiologists used to be very keen on, didn't we, Dr. De Belder, until we realized it killed people.
Yeah.
Steady now, you can have your say in a minute.
Well, Darryl, actually, on that point, we're seeing blood pressure reduction. It's just early days, and we may see down the line that there's harm from this.
Peter.
We've had 1 or 2 patients developing slightly high output states that they haven't tolerated very well. So refinement of who gets selected and things like that. That's all to come.
Peter.
Shouldn't it be mandatory in pursuing studies of these patients with resistant hypertension that the protocol demands that every single patient has had observed drug ingestion before they're allowed through to the procedure? I mean, in the 36 patients that we reported, 2/3 of them, after observed drug ingestion, normalized their blood pressure. And in talking to the Melbourne group about the Simplicity trials, the answer to the question was how many patients in those trials had observed drug ingestion, and the answer was none.
No, that's not true. We were a participant in Simplicity, and most of our patients in Simplicity either had been inpatients for hypertension control at some point, or they'd actually had observed tablet taking as an outpatient procedure, which is why I showed you data indicating that the blood pressure lowering in our group was very poor. And I think that if you have very resistant hypertension and are not succeeding on 5 or 6 drugs, then renal denervation may or may not work, and we don't know if that's because
we're going to have a discussion about that.
But the point I'll make is that we did do all that, so that's wrong information about Medtronic. It wasn't mandated in the study protocol, but that's what we do when we're taking patients for a device. But we also have another group to study, Peter, which is patients who say that they cannot take any medication because they're feeling wretched, or type 1 hypersensitivity reactions. So there's no drug trial for them that we do. We accept what they say.
Any other points? Yes, one in the middle. Wait, because we're recording all this, so if you could just wait to the... There we go.
For renal denervation, could we repeat it again if the patient show good response and then we lose the response? Could we repeat it again? And is it done in both sides or on one side?
Wrong timing for that question, I'm afraid. The answer is we shouldn't be repeating it, and it should be done bilaterally at the present time.
Just tell... Sorry.
Well, I think we're learning about renal denervation at the moment, and the evidence is that it's not safe to proceed with a repeat if you've done it. And some operators have actually gone on and done that. In Russia, there's been a study where a group has applied up to another 12 RF ablations per renal artery after an initial 8 to 10, showing substantial blood pressure reduction. I'm not sure if that patient's kidney arteries will last, the next few years.
Mel, can I just ask a question about these other device managements of hypertension? I mean, we're told that if you use renal denervation, that you continue the antihypertensive drugs. Is that the case with these procedures as well?
Well, I mean, these are all brand new, and in the Baroreflex study, the patients requested reduction of medicine because they were getting orthostasis with the original pivotal trial. In the follow-up studies, the numbers have been very small. In the ROC study that we're doing now, we've had some patients, they ask us not to adjust medicines as part of the study protocol. But in fact, we've had to do that in a couple of patients.
Right. I think actually we should, because if you have some questions about